Dr. Leonardi. He will tell us about multidisciplinary treatment of chiari malformation.
Con particolare riferimento al research news. Sono 5 minuti lei però, stavolta abbiamo controllato bene. A 1 minuto le chiamiamo alla fine, grazie.
Dottoressa...
Per cortesia, qualcuno può aiutare un attimo?
Perhaps someone can help the doctor. My name is Paola Leonardi, and I'm a nurse coordinator of Gemelli Hospital. I work with Dr. Valentini. I will talk about research nurse in the multidisciplinary team for the management of chiari type 1 malformation. When we first started planning the establishment of a team for chiari 1 malformation management, we wondered whether this team should also include a nurse, and what role the nurse would have, as this is a condition that doesn't just involve parents and relatives and children, but the patients themselves. Chiari type 1 malformation can be described as a drama including 3 players or actors: children, who are the innocent and who may become the victim; the family, who want to know about the disease and who very often resort to the web. The web may provide confusing information. And then there's the savior, who is doctors. We wondered whether there was a role for the 4th player, that is, the nurse, who should provide care and also research. So what's the role of a research nurse? A research nurse can be involved in the screening and recruitment of children in protocols, involved in the preparation of study protocols, collect data documentation and reports, and also spread information to relatives, information leaflets, consent forms, case report forms. The nurse should also make sure that ethic rules are complied with. This is why we think that the presence of a nurse should be advisable. The reason being that there are complex relationships between the multidisciplinary team and the family, and among members of the multidisciplinary team themselves. It is a heterogeneous condition with different clinical presentations. Because there is insufficient knowledge and because parents are anxious, a nurse is necessary. We therefore started a cooperative study aimed at collecting demographic findings. This is a video showing the amount of items in the questionnaire. The study also includes diagnosis and enables people to enter their diagnosis. There's also room for results. Within this protocol, a research nurse can make use of the protocol for her or his daily practice. The protocol is going to include children with all their various associated disorder findings, and the protocol also includes an alarm system that alerts nurses to exam bookings. This alert is also circulated to the family of patients and to doctors. At the admission of patients, the 4th player gives information to the family. and also gives information on the diagnostic pathway, on surgical procedures, both indirect and direct ones, for correcting the malformation. I'd like to highlight a study published in 2008 in Cape Town during a meeting by the International Society of Pediatric Neurosurgery that reported the results of a nurse research. Questionnaires were submitted to parents who had to sign an informed consent, and the study showed that the informed consent did not relieve anxiety or understanding of the situation, especially during the post-op stage. This was due to the lack of information to parents. So we believe that after administering the informed consent, a specializing nurse should provide information to the parents. The role of a research nurse is key because she facilitates work by the team and alleviates suffering. She can provide interaction between doctors and the group, doctors and the patient, and her features must be curiosity and an interest, reliability, ability to work in a team, and being sympathetic towards patients and their families. We were told that Dr. Aramini was not here, but she's now here, and she will tell us about the role of psychologists within a multidisciplinary team. You have just a few minutes. Hello, my name is Barbara Aramini, and I'm a psychologist. With my contribution, I will shift your attention, shift the focus from the medical to the psychological field, not to highlight a difference that's already existing, but rather in the hope of getting these two worlds closer. I think that the time of diagnosis is a time of crisis, and as such it can lead to a whole range of changes in the lives of subjects and their families. So I came up with the idea of envisaging multidisciplinary teams that also includes a psychologist. A psychologist who should be providing not only counseling, but also an opportunity for subjects to think about their condition and to make plans for their new life that includes their disease. This is due to the fact that at the time of diagnosis, several aspects are involved, ranging from perception of one's own body to the ability to deal with suffering. This can trigger a whole range of frustrations and needs and can affect self-esteem. Chiari malformation diagnosis, however, does not cause subjects to become psychologically diseased. A psychologist within the multidisciplinary team, therefore, can provide twofold counseling, therapeutic counseling and psychological and support counseling. The subjects who could benefit from psychologists' help are both diagnosed subjects and their families and the team of specialists itself. Why the parents? Because the members of the family are all unified, so a Chiari diagnosis poses problems to the entire family. So therefore, parents need someone to help them to deal with the sorrow caused by the news that their child has a disease, and they need to be helped to accept the limits that their children will have due to this malformation. What are the targets? The targets are not just psychological counseling. If just counseling was provided, subjects would not be able to improve. But if a psychologist gives the opportunity to subjects to process their state and to make plans for the future, this is much more valuable help. This is all the more important if subjects come to their diagnosis during their adult age. A psychologist can therefore provide relief, as these subjects may become depressed due to the fact of receiving this diagnosis. As for parents, a twofold contribution should be given by investigating their perception of their children's disease, in other words, how parents feel about the medical context. This means investigating the experience parents felt after receiving this diagnosis, and also in terms of their perception of their function as a parent. Training should be included so as to train other specialists on how to communicate with the patient's family, the patient himself, and other members of the team. Within a multidisciplinary team, a psychologist should therefore provide training and strategies for people to live with their disease. Therefore, I envisaged targeted interventions at the time of diagnosis, pre-surgery and post-surgery. This consists of 12 60-minute discussions over 12 weeks and 90-minute meetings with the whole family. When working with the other members of the multidisciplinary team, counter-transfer, that is the unconscious reactions of the doctors to patients, should be dealt with during meetings to be held twice a week. You've run out of time. Thank you. Mr. Marco Braida will come and talk about Chiari syndrome and vertebral deformities. He's always very concise, so he will help us to catch up with the schedule. Thank you for inviting me here. I'm going to hold a presentation that stands off the rest of presentations. I will talk about Chiari syndrome and spinal deformities, notably syringomyelia. Why is there this association? I will quickly run through the literature starting from the 1990s. At the time, magnetic resonance imaging was adopted, and people said that scoliosis could be the initial neurologic sign suggesting intraspinal pathology. This was supported by the theory that abnormal hydrodynamics of the CSF is most likely to cause neurological deficits associated with progressive scoliosis. These were the findings of a study by Jeanne Dubousseff, who is one of the most important pediatric orthopedic surgeons. So 15 to 20 years ago, it was recommended to perform routine MRI on scoliosis patients. In the late 1990s, however, a retrospective review reported that tonsillar herniation, incidental tonsillar herniation, is of limited prognostic utility. usefulness. Only 175 patients had tonsillar herniation of more than 5 millimeters, and 25 were clinically asymptomatic out of many patients. The association between progressive scoliosis and neuraxis malformations led us to suspect this association in some atypical curves, notably the left thoracic curve. Together with an Israeli friend of mine, we published a paper at the presented it at the 1995 Congress of the Scoliosis Group in Israel, and we noted that the rate of the presence of syrinx and chiari correlating with left thoracic curves was much higher than right curves. So left thoracic curves, long curves, or curves with a very high or low apex and an associated hyperkyphosis are often signs that should lead to a suspicion of a higher rate of spinal or neuraxis injuries. So, as Siegel reported in 2003, these curves lead to a higher index of suspicion. What is the incidence? I'd like to mention three papers. One by Gupta-Lenki. It was a review of MRs on adolescents with an incidence from 18 to 20% in juvenile and 50% in infantile scoliosis, notably at the site of neuraxis. So they recommended total spine MRI for young patients. Two more papers, one in Japan and one in China, performed on large groups of 250 patients and 203 patients respectively. Well, the first one showed that 18% of Japanese patients had syrinx or tonsillar ectopia, and 20% of those had abnormal neurological signs. I mean to say that this association is now fully acknowledged. Neurosurgical treatment, decompression treatment is recommended for pediatric cases as the first step in the treatment of these deformities. 71% of patients treated at an age of below 10 years with decompression did not develop progressive scoliosis. More recent papers note that decompression should be performed very early. This is a curve with a very high apex. Pre-op magnetic resonance imaging was performed, and we discovered syringomyelia, which was, of course, treated before spinal surgery. I would like to briefly outline this 29-year-old patient. She had hydrocephalus and spina bifida. She was operated on day 2 for meningocele, and she then underwent drainage 1 month after birth. She was given a brace, and scoliosis progressively worsened. The right picture shows that craniovertebral decompression with C0, C3 fusion was performed. And then we intervened on scoliosis at 2 stages when she was 15. In 2002, she was very active, but she then started complaining of dysesthesias of the upper limbs. Cervical compression was found, which was decompressed with a very good outcome and significant neurological improvement. You've run out of time. This girl is now complaining of lumbar pains, so we will have to address the lumbar sacral problem. In adults, the more severe scoliosis, the more severe the pathology. I'd just like to conclude by saying that I agree with Cheng, who says that lower tonsils, tonsillar herniation should always be regarded as an abnormal finding in scoliotic patients because scoliosis could be a sign of this herniation. Scornietti, rehabilitation after cord detethering surgery.
Ok, grazie. No,
Cercherò di essere breve.
I will try to be as concise as possible. My case report is about a young girl who was treated at Besta Hospital in Milan, notably by Dr. Valentini, whom I'd like to thank for inviting me here. This patient is a girl who is now 20. She was symptomatic right from her childhood. She had a malformed foot and she was operated on for that. She was clinically monitored and based on radiological findings, she then underwent detethering surgery, followed by immediate improvement of symptoms, notably headache and motor symptoms, which led to functional gain. Following that, she underwent rehabilitation. Her rehab course consisted of therapeutic exercise aimed at improving or stabilizing the previously found problems. She required pharmacological support for spasticity, and she also required orthesis to stabilize proprioceptive function. After 4 weeks of treatment, her spasticity significantly improved. Stiffness duration, morning stiffness duration improved greatly, and her headache disappeared, which is what she most appreciated. Postural tests were performed because proprioceptive motor control and balance disorders were present, as well as manual dexterity problems, showed asymmetry at 1 month. These were the initial and final load asymmetry. Sensory interaction tests were performed under different conditions on different surfaces with open and closed eyes, and there were huge differences. Barycentric oscillations were highly reduced after 4 weeks. Limits of stability tests were also very different. This is a pre and post test showing great improvement, especially in the interior part. However, this did not progress, nor was it stabilized, because 6 months after surgery, there was a reversal and headache reappeared, and there was a progressive deterioration of her motor skills and of her sphincteric function. The tools used to evaluate her functional autonomy did not highlight any reduction in her autonomy in personal activities. The FIM scores, which is more sensitive, however, showed that the improvement after 1 month was completely lost after 12 months. The total score was 170 after 12 months, which is lower than previously. Exercise, however, helped her gave her a benefit because rehabilitation helped her to regain part of her autonomy. Urodynamic tests showed that after 1 month parameters had improved. 12 months later, However, her cystometric capacity was apparently improved, but in fact it was due to drug treatment because her hyporeflexia and incontinence status had actually got worse. This is a summary of the balance test after 12 months, showing that in many tests there was a slight worsening, except in gait speed, which was still within the norm. This case report is still open. Together with my colleagues, notably Dr. Valentini, we are trying to envisage potential approaches, including surgical ones, in order to improve the situation. Thank you. Chiari malformation type 1, 3 case reports. This is a presentation that will be held by Dr. D'Angelo. Good evening. I'd like to discuss 3 paradigmatic case reports which are very useful when it comes to the timing setting. The first one is a 3-year-old girl with myoclonic seizures. MR showed tonsillar descent and Chiari 1 malformation. So what should we do? She was an asymptomatic patient with incidental findings. Should we proceed to just clinical observation, subject her to further diagnostic examinations, or what? What we did was a spine MRI with no syrinx evidence, neurophysiological studies, normal, polysomnography, which showed no sleep apnea, and ENT evaluation, which was normal. So we decided to continue with the clinical observation. 2 years later, she had worsening tetraparesis, and MR confirmed Chiari 1 with syringomyelia. She was admitted into hospital, and she had tetraparesis, superior upper limb hypoesthesia. So what treatment should we adopt? Suboccipital craniectomy, craniectomy and uroplasty, craniectomy and urolysis, lysis, craniectomy, uroplastic and coagulation of the cerebellar tonsils, or what? We opted for posterior decompression with tonsil coagulation and uroplasty. This is the picture pre and post. During post-operative course, her tetraparesis and dysphagia improved, whereas hypoesthesia and SEPS and MEPS were stable. MR showed decompression, but no modifications of the syring. This is food for thought as to timing and as to whether, if there's a syrinx, it should be clinically observed or treatment should be adopted. The second case was a 9-year-old girl with headache. Neurological examination was negative, and CT documented ventricular problems. MR showed hydrocephalon and tonsillar descent, but most importantly, cervical syrinx was found. What would you do? Would you continue to observe or resort to surgery? We're also wondering whether we should treat Chiari malformation or hydrocephalus. Since there was hydrocephalus and syrinx, as well as Chiari malformation, we treated the hydrocephalus with a third ventriculostomy, and at 6 months, these were the results. This is the third case report. So this was a 10-year-old girl who came to our observation with diplopia and strabismus and nystagmus. MR showed Chiari 1 malformation with a hollow cord syrinx. What should we do? We wondered clinical observation only, further diagnostic investigations, or surgery. Surgery was not indicated. So we carried out a suboccipital craniectomy and C1 laminectomy. Post-op, she was stable, and her syrinx was stable. At 6 months, the syrinx was still there, but the girl was worsening. She suffered from dysphagia, as well as nystagmus and diplopia, and as well as Babinski reflex, which was positive. We decided to carry out a duroplasty. 1 year after the second surgery, she was worsening again. She had a paralysis of the hemilarynx, and there was a persistent posterior compression and a persistent syrinx. So we performed a CT scan, which showed a newly formed bone. So what treatment should we perform at that point? We performed a third surgery step with extradural scarring tissue, and this is a picture of the surgery procedure showing how the bone was removed and the scarring tissue was removed as well. At follow-up, there has been a clinical improvement. MRI shows good decompression, but the syrinx is still there. So now we're wondering whether we should further treat the syrinx or stop. Now we leave the floor to Dr. Casali, treatment of Chiari 2 malformation and syringomyelia in myelomeningocele.
Sì.
The title was modified. Our experience about Chiari 2 malformation, I'll show you 3 cases. They were all operated at birth for myelomeningocele. First case, a 26-year-old male that was sent back to us with a symptomatic syrinx, so with progressive weakening of the upper limbs. The X-ray showed a cervical dorsal syrinx and the presence of ventricular distension. This caused over time the development of major macroprenia. The first choice was to perform posterior fossa decompression. As you can see here, there are some 3D CT scans showing craniectomy, arthroccipital craniectomy. We also carry out duroplasty because we believe this can be beneficial and can better restore the CSF flow in the posterior fossa. 6 years after this patient had a worsening of the syrinx. From the neurological standpoint, the symptoms did not progress. Don't have pictures, but we still had the ventricular distension, so the second choice was to carry out a third ventricular cisternostomy. From the neurological standpoint, this patient, despite stability of the hydrocephalic picture and of the syringomyelia, showed a slow though progressive worsening of the asthenia of the upper limbs. The second case referred to was 19-year-old girl that was referred to us with mixed symptoms with endocrinial hypertension and syringomyelia. The first choice was, and this is the CSF flow in the posterior fossa showing a remarkable decrease and presence of syringomyelia of the cervical area. So the first choice was posterior fossa decompression. 3 years later, the patient came with syrinx progression and persistence of the hydrocephalus, and therefore the second choice was to perform a ventricular peritoneal shunt. And of course, she was submitted to review, and then and also she developed, however, a slow worsening of the daily, let's say, autonomy for a progressive worsening of symptoms in the upper limbs. This is the last case, 24-year-old boy. At 1 year, it was admitted to surgical shunt for hydrocephalus. At 7 years, syringosubarachnoidal shunt for syringomyelia. At 21 years, apneic spells developed, despite the radiological pattern was unchanged, and so we decided not to perform any surgery. 3 years later, he was sent to us from the emergency ward of another hospital, intubated and sedated after an acute respiratory arrest. Radiological images showed the syrinx, but the clinical picture was unchanged compared to previous years. Decompression was performed with dural-plasty. I know I have to complete. This is the outcome, and this is the complication that developed, because unfortunately he did not recover immediately the physiological respiratory pattern. We had to decompress him with a further superior occipital craniectomy. This is post-op outcome. Now he has recovered from the neurological standpoint, his respiration. Certainly, this is a severely impaired patient. This is about our experience. What have we learned? We have certainly learned that the first step with these patients is to ensure a physiologic intracranial pressure, so either a ventricular sternostomy or a shunt. If in case of worsening and in case of shunt, we have to verify whether the shunt works and the patency of the stomia, and then CVD in vulvisyrinx, also asymptomatic, because when they become symptomatic, it's hard to solve symptoms. And then occipital craniectomy. Be careful, these patients have malformations. The transverse sinuses are in a lower position, and therefore it's somehow easy to cause bleeding. Well, I'm done. Thank you.
Chiamo la dottoressa Laura Valentini.
I invite Laura Valentini now to tell us how to handle the round table.
No, anche qualcuno che chiama gli altri. Secondo me deve vedere qualcuno. Vai, vieni qua, Andeo, siediti. Non puoi dire. Siediti, vieni qua. Dai che sono stufi, allora, tutti sono stufi.
Noi avevamo preparato delle domande.
Well, we prepared questions to discuss, and so we would like to know whether your comment so as to, in the end, draw up a document to give our patients.
Allora, queste sono le domande.
These are the questions. These questions are open to all of you, and if you want to make a comment and answer, feel free to do it. For neurological clinicians, we have to understand that when we indicate MRI in a cephalagic patient suspecting ACM, should we do it on everybody, adults and children alike? So this is the first question. We only have Dr. Salefti.
generally speaking, a child of less than 5 years of age who suffers from headache should undergo MR because under 5 years of age, headache is rare. The features we mentioned this morning apply if it's occipital headache, if it's accompanied by nausea and vomiting, and if it increases with Valsalva's maneuver, MR is indicated. And always, if children are below 5 years of age, neurological examination and eye fundus examination is also required, but below 5 years of age it's necessary. I do not see any radiologists left here. The second question is aimed at radiologists. The question is, which are the MR diagnostic criteria for M1? These are the criteria. And what are diagnostic criteria for CARI 0, CARI 1.5, and CINE MRI criteria of CSF flow analysis? How to exclude by clinic and MRI full CM as tonsils descent due to intracranial iatrogenic hypertension? Because today it was recommended that MR should be always performed with contrast medium. I don't see that there are many people left in the hall, so CARI 0 is in the previous page. I have many doubts about CARI 0 malformation, so I'd like to discuss it with Dr. Pina and make the most of his presence here. He's still here. We can make it further clear that there is no clear definition in the literature of CARI 0 malformation. I outlined case reports. I thought I would give a definition of CARI 0 in adults because to date there are only CARI 0 definitions for children who have been extensively studied. CARI 0 case reports are different in adults and children, and the adult case reports I introduced are in fact benign CSF alterations. So if you give me 1 minute, I will tell you that CARI 0 does not exist, and it doesn't make sense to talk about CARI 1 and CARI 1.5. CARI malformation is a functional disorder. I'm sorry that there are no radiologists here because we need their contribution. Something that we're doing in Modena and that's also being done at other centers such as Chicago, Munich and Johns Hopkins University is providing indications to better define these patients. This is one approach and it may not be the right one. I would also like to mention the so-called CARI project, which is a cooperative study that we have undertaken and that will last 3 years. We are collecting cases, all sorts of cases, which are still being defined as CARI 1, CARI 0 cases, but we are trying to find out what alterations of the parameters I tried to quickly explain earlier are found in patients who are symptomatic, asymptomatic. In other words, how we can identify clusters. The definition of CARI malformation as has been given so far in radiological findings is probably obsolete. Not much is required. An MR is required and a given protocol needs to be applied, which is very easy, by the way. It's not the end of the world. Interestingly, sometimes we see patients who have remarkable CARI 1 malformation and who are identical to CARI 0 patients, and they're asymptomatic as well. So it would be interesting to define how CSF fluid works in these patients who have Chiari malformation who are asymptomatic. I think that we're going beyond the classic radiological function, and we're resorting to a functional definition. As to the functional definition, I have a question for Dr. Pinna. In terms of morphology, which is very important for children, should the morphological approach be applied also to adults to see if there's an important relationship between the volume of the container and of the content that is at the posterior fossa site? Undoubtedly so. As I said previously, in children who have a skull that's still developing, first of all, I'd like to say that Chiari malformation is not congenital. It's always acquired, so much so that no in utero diagnosis has ever been made. When the cerebellum develops, there can be anomalies of the content leading to Chiari, but this is just one facet. After adolescence, adults already have a fully developed skull, but there are other factors which are still unknown, neither for children nor for adults. Certainly, a CSF disorder component, which we are not able to define yet, is there. It will have to be defined both for children and adult patients based on well-known data and morphological parameters when there is a small posterior fossa. Benign CSF hypertension does exist, but in that disorder, tonsillar descent is 8 times higher than in Chiari malformation. So this means that there is something additional, and this additional something is something that we haven't yet been able to define, and that is related to CSF disorder. Let us move on to the next question, that is, what investigations should be done for patients who are referred for surgery? This is a question about surgery indications. Well, with surgical indications, what would you do? What should be the mandatory investigations? Flow, MR for investigations of the venous sector. I don't want to be the only one taking the floor, but I'd like to say that we have a very strict protocol concerning MR investigations at the pre- and post-surgery stage, because it's important to figure out what happens after surgery as well. Other important questions are, should asymptomatic Chiari patients be subjected to surgery? If you incidentally find descended tonsils, what's your indication? A patient may have a searing and be asymptomatic. I have my own idea about this, but what do you say? I think that to find a clear course, we should talk about Chiari's anomaly, and Chiari's anomaly involves a tonsil descent into the cervical space, which can be more or less extended depending on severity. Some symptomatologies can overlap Chiari, but if there's no tonsil descent, and I do not agree much with what Giampiero said. You said that there are benign intracranial hypertensions. Maybe it's true. Do you measure pressure? Yes, we are measuring pressure. I can confirm that it is so. Good, but I suggest that an anatomical abnormality should be involved, otherwise we won't find our way anymore. So the key is what should be done with asymptomatic Chiari patients, because if there's symptomatic syringomyelia, there's no point in discussing what should be done. We all know what should be done. The point is what to do with a small syringomelia and asymptomatic Chiari malformation. I think that these are the most problematic patients. Waiting for it to evolve is bad. You said earlier that when symptoms appear, they're very unlikely to disappear, especially those symptoms that are related to the syrinx. So should syringes be operated on? Do you say that when there is a syringe, surgery is indicated? I think that a difference should be made. If there's a child with Chiari and syringomelia, surgery should be performed. With asymptomatic patients, adult patients with Chiari and syringomelia, I wouldn't perform surgery, but I think that a child should be operated on. I sort of agree, but I would say that if a syrinx is asymptomatic in children, and in children it is rarely asymptomatic, I do not see any indication, but these children should be strictly monitored. What do you mean by monitoring? We have seen syrinxes that have evolved in 2 months' time in children, and together with orthopedists and pediatrics and Dr. Colombo, we have established that when scoliosis is established, there's no going back. Syrinx-related symptoms are scoliosis, and often it's a scoliosis that doesn't reverse. So waiting for scoliosis to appear in a child that's then difficult to fix is no good. With children, I do not have much experience. Well, adults do pose problems too. I mean, we're responsible in legal terms as well in our procedures, and this is affecting our way of proceeding. So I don't know what to say about adults with syringomelia. The opposite could be true. I mean, performing defensive medical procedures. You know, when you talk about being legally responsible, we do not know much about this disease. There was a very good presentation about this, but I don't think that we can come to any conclusion. In those disorders where there is no light on natural history, there is a lot of room for prevention. And what about follow-up for asymptomatic Chiari patients with a syrinx? How should follow-up be organized? How often should follow-up be performed? As for adults, I would say that if there are heavily altered CSF parameters, more often than once a year. Otherwise, once a year is fine if patients are asymptomatic. We do not have enough data to say that asymptomatic patients have altered CSF parameters. Following this study, hopefully we will have an answer. We will have more data about this. This is why we have undertaken this international cooperative study, which is aimed at shedding light on asymptomatic Chiari malformations to figure out what should be done. I don't think that we can provide an answer to this. We should just act based on common sense. I think that these patients should be clinically followed up rather than radiologically followed up. Symptoms should be checked periodically, as well as other tests, not just MR, considering that with children it's necessary to give them general anesthesia to perform an MR. And by the way, it's not possible to perform MRs frequently.
No, l'ultima cosa è che tipo di restrizioni applicare nella vita di quelli che decidi.
And what limitations should we apply to patients that are not operated? Some centers say shouldn't do anything, as Carmen has said, a 6-year-old child, and then we tell this patient not to do any sport, for instance, dancing or playing soccer. As I said during coffee break, it takes some common sense. You cannot establish a fixed rule and a ban on sports. I mean, especially if a child is asymptomatic and during the sports activity has no symptoms, why should we forbid that? This is important for parents because it is very important for us to encourage them and tell them what to do. In any case, I'm